Hello, everyone, and welcome to Substance Use Across the Lifespan, supporting every stage, an immersive podcast, toolkit, and workshop series created in partnership with the Opioid Response Network. I'm Marlene Martin, an addiction medicine physician and longtime member of the MRSA community. For those new to the podcast, MRSA is a national organization dedicated to bringing together disciplines and perspectives to strengthen substance use care through collaboration, evidence-based practice, education, and advocacy. This podcast series explores how substance use care evolves across the lifespan, from childhood through older adulthood, highlighting the developmental, social, and clinical factors that shape care at every stage. Joining us today is our host, Dr. Jimena Levander, an addiction medicine physician and clinician researcher at Oregon Health and Science University. Her work focuses on care for women who use drugs, particularly in perinatal settings. She is joined by Gabriela Zapata Alma, a nationally recognized expert in trauma, substance use, mental health, and violence, and Associate Director at the National Center on Domestic Violence, Trauma, and Mental Health, and Heather Phillips, Research Director at the Center, whose work centers on survivor driven research and the intersection of intimate partner violence and substance use. Presenters report nothing to disclose. Thank you for being here. Let's get started.
All right. Thank you so much, Marlene, and welcome everybody to the podcast series. I'm your host, Dr. Jimena Levander, and today we're talking about substance use coercion and how we can build stronger systems of care at the intersection of substance use and intimate partner violence. We're joined today by Gabriela Zapata Alma and Heather Phillips from the National Center on Domestic Violence, Trauma, and Mental Health, who bring deep expertise in research, practice, and system capacity building at the intersections of domestic violence and substance use. And we are so glad that they're both here to join us today. To frame our conversation, here are three themes to listen for while we're having our conversation. Identify the defining features and the prevalence of substance use coercion within intimate partner violence, or IPV contexts. Describe how substance use coercion creates barriers to safety, to treatment access, and recovery outcomes for survivors and their children and families. Explain how the Project ECHO model supports cross sector capacity building between domestic violence and substance use disorder service providers. Let's jump right in. Thank you so much for joining today.
Thanks so much for having us.
First off, for folks who may not be familiar, can you tell me what is substance use coercion and how does it show up in the lives of IPV survivors?
So, substance use coercion is a unique pattern of intimate partner violence, also known as domestic violence, that is a pattern of control and harm that seeks to leverage either a person's substance use or stigma related to substance use to harm, isolate, and control survivors, as well as turn systems of care against them.
Any ways on how it shows up in the lives of survivors of intimate partner violence?
Yeah, it shows up in many different ways. One thing that we're always really concerned for are ways that people who harm their partners can utilize substance use coercion tactics against survivors when they attempt to seek any sort of health care, including substance use disorder treatment services. So they may do things like actively prevent them from being able to access appointments, make sure that they don't have transportation to attend, or they might steal or divert medication that they use to manage their substance use concerns. So there's a broad spectrum of things that happen when people who experience substance use coercion seek or attempt to seek treatment. That can be barriers.
As an addiction clinician, hearing all those different ways that substance use coercion can show up is certainly something that I feel a lot of folks would want to know more about. How does research tell us about the prevalence of substance use coercion? How common is it?
Yeah, so this is something that at the center over the past 12 to 15 years, we've been learning more and more about this. We did a survey with the National Domestic Violence Hotline in 2012. And 15% of people, it's just a general survey, anybody regardless of their substance use status, 15% of people reported that they had tried to seek support for their substance use concerns. And of that 15%, 60% reported that their partner tried to interfere with that. And right now is an exciting time because we're currently learning a lot more about the prevalence of substance use coercion from a large national survey with results forthcoming. But we're seeing in general prevalence rates for the entire population between 30 and 70%. But then by social location or substance use experience, those prevalence rates vary, as does the impact of substance use coercion.
Wow, those are really surprising findings. Go ahead, Gabriella.
Yeah, we also did a literature review in recent years. And so, looking at the prevalence specifically in substance use disorder settings, we found that some studies had prevalence rates as high as 90% of the women accessing substance use disorder care. So, really, really high numbers. And that is especially high in opioid use disorder care. And in some ways, it's not super surprising when we understand that being abused by an intimate partner violence is associated with a 6 times higher risk of developing a substance use disorder.
So these risk factors go both ways, it sounds like, that people who experience intimate partner violence have higher rates of substance use, and that people who have substance use, higher rates of intimate partner violence, and this overlay of substance use coercion. I'm really excited to hear more about the follow-up results of this survey. So I will certainly be keeping an eye out for those results. And I'm asking folks who are listening now to consider how they currently assess for substance use coercion in their treatment services. I'm currently starting to think through the different treatment settings that I work in and how we may or may not be appropriately assessing for that. Can you talk a little bit about some of the training gaps that you're seeing in behavioral health and in the recovery workforce and being able to assess for substance use coercion?
Yeah, so we found really huge training gaps. So we did a series of key informant interviews as well as some different needs assessment, large scale needs assessment that found that the vast majority of, you know, really multidisciplinary, looking across physicians and addiction medicine and nurses and social workers, right? Just really looking at a lot of the people who may be involved in helping survivors within a substance use disorder treatment setting really did not have as part of their core curriculum any kind of coursework or training around domestic violence or intimate partner violence. And then in our conversations and assessments in the domestic violence field, we also found similarly that there's not a whole lot of access to this information and this training. And when people have had training, a lot of times the vocabulary they use is completely different, and their theories of care, their theories of change, their philosophy of care is totally different as well. And so once people do get some training, a lot of times then we still see gaps and barriers when they're trying to communicate with one another. And so domestic violence advocates are going to come from an empowerment based approach that's really focused on person centered services and survivors defining their own goals and their own needs and what's safe for them. And then on the other hand, when people in a treatment setting have been trained, a lot of times they may have been trained only on some of the most obvious forms of domestic violence or some of the most kind of ways that domestic violence shows up in a crisis. For example, things like asking about physical abuse. And they really haven't gotten the information on the subtle and the nuanced ways that substance use coercion can show up. And then a lot of the theory of change within the substance use disorder field, things like, people taking responsibility over their substance use and their substance use disorder and recovery, isn't actually really a good fit for survivors because it really misses the context of how a survivor's substance use and their attempts at recovery may be intentionally harmed and blocked and sabotaged by an abusive partner or ex-partner.
That's all really helpful framing and really gets me thinking about my own training and work in treatment settings. Why do you think there is that gap in training in this area for people who work in behavioral health and who are in part of the recovery workforce?
Well, violence flows towards those with less power very often. And so many times the people who have been disproportionately impacted by domestic violence are not the people who have the most power, who have the most representation. And so while it is incredibly pervasive in our treatment settings, it's not what has kind of held the focus and the narrative within our treatment settings. Another piece is that domestic violence really seeks to make itself invisible and to normalize itself. And so we're talking about really a syndemic between intimate partner violence and substance use disorder, but one of those is really trying to make itself not seen and not noticed. And survivors can face a lot of harm and escalating danger when they do talk about the substance use coercion and the domestic violence they're facing. And so there's just a lot that goes into preparing the setting for being able to support survivors. And to be really fair, our training programs are already chocked full of so many different topics. I lead the addiction counselor training program for the University of Chicago, and already all the standards that we meet as an accredited program, it's like sipping from a fire hose, right? There's so much to cover. And so one of the things that we did that is actually different from this toolkit that we're going to talk about, but maybe worth mentioning here, is that we did a collaboration with the Behavioral Health Equity Resource Center to create a curriculum infusion packet focused on intimate partner violence and behavioral health. And so, if you're listening to this and you are an educator in the field and you want to find a way to include it, we have a whole curriculum infusion packet that you can include in your program.
I appreciate you directing folks to other additional resources beyond this like amazing toolkit that you all have created. It's a plethora of resources. One of the things that I think would be helpful for listeners to learn a little bit more about is the concept of cross-sector capacity building and why cross-sector capacity building is so important when we're trying to work on this like hidden, invisible issue across substance use disorder and domestic violence fields and why it's so critical at this intersection to have that cross-sector approach.
Yeah, I think that one thing that we hear from a lot of providers and domestic violence advocates is as they learn more about the intersection of domestic violence and substance use, they more often see or understand that their services are serving the same groups of people, but from different directions and in different ways. And connecting to what Gabriella was just sharing, every field, every discipline has its strengths and its ways that they can offer to support people. So, collaboration, particularly cross sector collaboration, deeply understanding the philosophies, the theories of change, the views of what well being and healing mean, what safety means, is important when we're thinking about supporting survivors who are experiencing substance use related challenges. So we love to see programming that allows for integration of both people who have expertise regarding domestic violence, like domestic violence programs, and then also who provide services that address substance use disorders.
And we know that integrated care for substance use and trauma is the gold standard, and that it's something that I think our field has done a really great job over the past 20, 30 years in being able to really meet the need and create a lot of different evidence supported programs for treating substance use and trauma together. But we still have more we still have more to learn and we still have more of a ways to go when it comes to supporting the needs of survivors for whom we're not talking about a post-traumatic, syndrome or disorder or stress. We're talking about current ongoing danger that they're facing. And so in that way, we still have a ways to go. And knowing that a lot of times people equate safety with being able to leave a relationship with someone who causes harm, but that very often survivors, if and when they do leave a relationship, the harm doesn't stop then. Very often, there's prolonged legal proceedings, there's ongoing stalking and assault and abuse, and that can last for years afterwards. And also that when people are attempting to leave a relationship or have recently left, that's one of the times that they're at highest risk for being killed by an abusive partner, as well as the other highest time, highest risk of being killed is during pregnancy and in the post pregnancy phase. We know that homicide is a leading cause of death during pregnancy and post pregnancy, and that those homicides are by and large related to intimate partner violence. And so the lack of training and creates these huge gaps that reduce safety and create barriers. And survivors end up caught between two systems. Very often, they try to access help in one and they get bounced to another, or they fall out of care, or they get exited or discharged out of care because of the lack of understanding of substance use coercion. And what we also found through surveying different state behavioral health agencies and surveying domestic violence organizations and coalitions is that people really want cross training. They really want to address these partnership gaps. They want to have streamlined, ready access to one another so that it truly can be a no wrong door approach. And so, something that is really special about this particular way of supporting cross training is that, and kind of provider education, it's that at the same time that we're helping to increase knowledge, we are also helping to increase collaboration and relationship across these fields. A lot of times, physicians and midwives and nurses and other providers, they say, well, if I ask about this, I need to be able to refer somebody, right? I can't all of a sudden, become a domestic violence advocate. And so something that's really beautiful is that while yes, integrated care really does make a world of difference, at the same time, we don't need one person to have all those different areas of expertise. What we need is for them to have enough expertise and then to be able to build partnership and relationship with the other experts so that the provider on the substance use disorder treatment side can be a bridge and support that person to being able to access domestic violence advocacy, for example.
I would like to invite listeners at this stage. I'm thinking on, our own, my own communities and systems that I work in. Like, where are those silos? How are we continuing to, despite all these efforts to integrate care to try and break down those silos and really try and integrate systems? I'd be curious to hear from your research. What were some successful approaches for folks in trying to break down some of those silos?
Yeah, so we have been engaging in two pilots. One pilot is a statewide pilot, and another one is one within a medical center that is seeking to increase the well being and safety of domestic violence survivors who are using substances by addressing substance use coercion in really universal and very grounded ways. One example that I can give you has to do with work that we've been doing with the University of Pittsburgh, where there is a domestic violence advocate who has done an internship and received training in a clinic that supports pregnant and parenting people who use substances. And from there, we were able to build upon that and further develop relationships while also universalizing approaches to open conversations about substance use coercion. In addition, there's practices that are really common that sometimes surprise people that need to be shifted. This includes making sure that patients are roomed alone, including when discussing what might be going on within their relationship lives. So, yeah, and providing universal education too to patients so that they understand that this may be a form of abuse that they're experiencing.
It'd be helpful, I think, for folks who are listening to maybe provide, and you've provided a few, but some specific barriers in different types of substance use disorder treatment settings that people might want to think about when they're going through their own exercise of sort of evaluating their own systems. So, like, maybe what are some of the barriers in like a residential treatment program versus maybe like a methadone clinic, opioid treatment program, or like an outpatient clinic or a hospital system. Folks with MRSA, I know, are part of different types of treatment settings, and they're probably different barriers.
Yeah, I can speak to a couple of things, and then I would absolutely defer to Gabriella. I think a couple of things that we've learned for people who are accessing methadone treatment is that the regularity of these appointments means that it's really easy for them to be stalked by their partners or ex partners. In addition, for people who are pregnant and using methadone, we've heard many stories that they've shared that their partner has pressured or forced them to go off of sometimes even pretty high dosages of methadone with unfounded concerns about the health of the baby or the well being of the baby. Yeah, so I'll pass it along to Gabriella, but those are two things that we think about within methadone treatment settings.
Yes. And so, supporting survivors experiencing substance use coercion requires flexibility, creativity, and believing survivors. And so, anywhere in our systems where there is rigidity, where there are blanket rules or interpretations that don't take into account a person's individual context, that creates potential barriers and even potential danger for survivors. And so there needs to be flexibility, and there also needs to be empathy, right? A lot of times there can be this kind of jumping to conclusions. For example, well, a person who may be experiencing transportation barriers, it's much more likely that a clinical staffing might include comments like, well, are they really motivated? Are they actually motivated? If they really wanted to be here, they'd figure it out. Versus, oh, is this person having their transportation sabotaged? Which is an incredibly common form of a substance use coercion tactic. Having previously been the director of substance use disorder treatment programs where we provided co-occurring enhanced programming for co-occurring mental health, what we just saw it all the time that somebody would miss a scheduled appointment, make it in maybe later that day or the next day. And when we welcomed them with open arms and we were able to say, I'm so glad you made it in today. What helped you make it in? What happened, right? And taking that kind of approach versus an approach that is more like, you missed your appointment, you have to come back another time, right? That what we would learn from people is that, there was a partner who promised that they would be back with the car, and then they mysteriously were missing during the time of the appointment and they couldn't get access to the car to come to their appointment. Or the partner went through their wallet and took their bus pass that we had provided, and then when they woke up, their partner was gone with the bus pass and wasn't answering their phone. And we also saw this a lot with something that Heather mentioned earlier, which is having their medication stolen, buprenorphine stolen, even their methadone potentially if they had take homes, and that a lot of times our systems are set up for, in some ways, being very suspicious and surveilling people, and that is going to create a lot of barriers for survivors. There's actually a little mini guide that is available from our center, the National Center on Domestic Violence, Trauma, and Mental Health, that I authored that's called 7 Common Practices in Substance Use Disorder Care That Can Harm Survivors and What You Can Do Instead. Right? So there's a lot of pieces outlined for providers. But something else that we see too, and something that we've heard a lot from survivors, is this idea around personal responsibility that comes from really the moral model of understanding substance use disorders, and this idea that if your life gets hard enough, then you'll make the decision to engage in your recovery. And it's really missing the contextual pieces and the constant emotional abuse and psychological attacks and denigration that survivors already face. And so having heard from survivors that they're trying to get support and access, and when they say that they're experiencing domestic violence or substance use coercion, usually in other words, not using those words, of course, that sometimes the response they get is being asked, well, what's your role in that? What's on your side of the street? How did you contribute to that? And it really comes from this place of, I think, wanting or trying to empower the survivor, but it's not the right fit. It's within this kind of traditional, very, very individualized narrative of recovery. And it's really missing the actual reality that survivors face. And so there's a whole host of different pieces that come into play that create barriers for survivors. And we hear about those barriers across all settings, right? From crisis and emergency to outreach to outpatient, intensive outpatient to inpatient and residential. But the place that we also, I would say, hear about it most, it does tend to be in residential, in inpatient and recovery homes, as well as inpatient treatment, as well as within DV shelters, right? When we ask people, how often do you see substance use coercion? How many people in your program are experiencing substance use coercion? And usually the first question is, well, what the heck is that? And then once we describe substance use coercion, the vast majority of responses is, oh my gosh, I think everyone we're serving is experiencing that. And so it's really ubiquitous and at the same time, very insidious.
Yeah, it's a dangerous combination. I just want to reflect that, like, I can feel in my body that difference between approaching patients with suspicion and approaching patients with curiosity, like how that feels different and how that could feel in a clinic visit or a particular encounter. Heather, were you going to say something?
Yeah, and I really appreciated what Gabriella was saying about the importance of empathy as well. So, if we take a moment and think about what it would be like, there's a power differential between a patient and a provider, usually, and you're experiencing a form of abuse that also rests upon power dynamics. And thinking about what it feels like, what it would be like to open up to a provider. What are the conditions that help to generate trust and trustworthiness? And there's so many reasons why people don't talk about it. And for people who have children, there's often a well-grounded and distinct fear of child welfare reporting and loss of child custody that is a significant barrier to either even trying to get services or once you're in services to tell anybody about what might be happening within your life. So I think holding everything that we're thinking about in this conversation and then thinking about your patients, the people who you're supporting within your work, and really reframing things in terms of empathy and curiosity, and respecting reasons why they might share what's going on or they might not.
No, thank you for that added reflection. I think this is a great segue to move into the work that y'all have been doing with the toolkit and the Project Echo model so folks can find a way to develop some of these skills and the cross-sector collaborations in their own communities. So could you talk a little bit about the Project Echo model and how it supports this really important work?
Yes. So some folks may already be aware of the Project Echo model. It is this incredibly evidence based model that is all about democratizing access to specialty knowledge. So the focus is on bringing specialty knowledge to the people who need that kind of care and support rather than trying to shuffle people across all kinds of areas, rural environments, etc., rather than trying to shuffle people to the few specialists that exist. So it's about bringing knowledge to the people rather than people to the few specialists. And so in this way, Project Echo it was developed originally for helping to bring specialty medical care to rural environments. And it came out of the University of New Mexico, who continues to lead the Project Echo. And so we decided that that was something that, based on how effective it is and the way it's been used across so many different topics and settings and disciplines, that we thought that that would be really the best fit. So we went through the process to become a Project Echo partner to be able to develop and then pilot this Echo toolkit. And we also were the first ECHO model and curricula that was focused on intimate partner violence. And so, building on the success of Project ECHO within medical settings and within behavioral health settings, we then brought that focus on intimate partner violence and substance use coercion.
And what did you all find with this pilot that you all developed?
What we found was now this was a pilot. It was in Colorado, and it was tested across rural, metropolitan, suburban, and frontier communities with equal effectiveness. And what we found was some really major gains in both knowledge about domestic violence, substance use, and substance use coercion, as well as dramatic increases in provider confidence, which we know that that is essential, because if a provider doesn't feel like they can do it, then they're not going to ask the questions. They're not going to try to use the tools, right? And rightfully so. We do want to stay within our scope of ethical practice. And so, just to highlight one key finding, we found that from baseline to end of the curriculum, that provider confidence increased from 54% to 99%.
Wow, that's a really dramatic increase in confidence. And how did you find folks were able to help develop some of those like cross sector collaborations that we talked about earlier by using this approach?
Yeah, so we asked people about their ability to refer to one another. So we asked folks working in substance use disorder fields their ability to refer and actively connect to domestic violence advocacy and vice versa. And we found great increases there. We then also asked people about the strength of their professional network and how able were they to reach out to somebody in the different field, to be able to consult, to be able to ask questions, and also found really great increases there. And then, as a part of the model, we developed, not only are they in the same virtual room, because Echo's always done virtually, not only are they in the same virtual room, kind of building the same kind of vocabulary and common knowledge and information, right? But they also are building relationships with one another. And as a part of the toolkit, we also talk about many ways to help strengthen that collaboration outside of the virtual trainings, which included things like having an online hub that everyone had access to and continues to have access to, where they can the conversations, continue resource sharing, and continue to connect. And so that was it from our Colorado pilot. That was a formal pilot. But we also did kind of a pre pilot in West Virginia as a part of our West Virginia state model, where we also had regional teams. And Heather, I wonder if you'd want to speak to some of the work that we found with our regional teams and looking at network connectedness.
Yeah, so within the statewide pilot project that our team has been doing in West Virginia, and in partnership with many, many people who have been doing this work, for years and decades in West Virginia. We have used a regional team approach, which is especially helpful given how remote and isolated many areas of West Virginia are, and also the centrality of relationships within West Virginia culture. So this has been really helpful when we think about some areas that are very isolated, very low resourced, in ensuring that people who are experiencing substance use coercion are able to access resources, services, and supports that they need. And as a part of our evaluation of this project, one really interesting and notable finding has been the high level of network connectivity. And we see that shifting from baseline to final, where we have much more connection between people. Relationships are important when we think about trauma, when we think about domestic violence, we think about the role of isolation. And even thinking on a macro level, the importance of connection, making sure that you know people who can offer support, and then also cross-sector and cross-disciplinary work.
It's great to hear about how successful this toolkit has been in like two very different states, West Virginia and Colorado. And I'm sure folks who are listening would love to know about how they can get access to the substance use coercion echo toolkit, like what's available for them right now after listening to this podcast.
Yes, so we have many, many things available. So we have the original Substance Use Coercion Echo Toolkit that was originally funded between SAMHSA and the Administration for Children and Families. And within that toolkit, it includes how to form your project team, how to connect the multidisciplinary team within the project team that is then going to plan and implement the curricula that is within the toolkit. So we have two different curricula. One is the original 12 session. That was the one that was formally tested. And then based on that and knowing that in a lot of different settings and for a lot of different providers, 12 sessions is a lot. And so, based on those findings, we also created an abbreviated 8-session model. And that follows the traditional ECHO approach, where the first half of it is more didactic, the second half of it is applied learning based on a case. Now, there is one thing that we did change about the ECHO model, otherwise, it was done with absolute fidelity to that model. The one thing that we changed was that rather than real live cases, we developed scenarios. And so within the toolkit, we have not only those scenarios, but also guidelines for adapting those scenarios to maintain efficacy. This is something that I discussed with the Project Echo folks, and that they agreed, and we mutually decided that scenarios would be the best for this situation. Because what you're sharing in a case when you're talking about intimate partner violence and substance use coercion, there's social facts about a person. Things like, how many children they may have, or, just different, things that they may be dealing with in their life that would make them very recognizable, especially in smaller communities, including rural communities, frontier communities, island communities, where people tend to know each other for generations. And we know that confidentiality is a safety need for survivors. And so, based on that, it uses scenarios rather than real life cases, which some folks listening may actually find relief about, because I know that a very common challenge when administering and leading the ECHO model is getting people to volunteer cases, and to present cases. It also includes best practices for engaging lived and living experience faculty as a member of the project team, as well as special guest faculty. The toolkit also has a range of different resources, some of which we've already been mentioning, that help people to really implement the changes that are needed in their setting, as well as understand at a deeper level what substance use coercion is and how it impacts the people that we're serving. And then it also has a whole it spells out implementation from beginning to end. So from pre planning phase to the follow up phase. And then it includes a kind of step-by-step outline of what we did in Colorado, including our lessons learned. So it really is from A to Z how to implement this toolkit. And then even if you're not ready to implement a full ECHO curriculum, there's a lot of different things in there that people could start doing right away. And as a part of this podcast with Immersa, we are also going to have a workshop taking place on May 21st. And along with that, an abbreviated toolkit so that if you're not ready to fully jump into the toolkit, but you're curious to learn more, you can join that workshop and you can also look at that abbreviated toolkit to get some ideas around how to get started.
I really appreciate all the work that y'all have done in this area and the thoughtfulness and be able to create this more extensive toolkit, even going from the 12 sessions to 8 sessions, and now also this workshop and a more abbreviated toolkit. It's a lot of resources for folks who are interested in wanting to engage more in this area, which I certainly am after um, hosting this and preparing and having this conversation with you all. You also mentioned best practices around engaging with folks with lived and living experience. And what are some best practices and supporting folks who you may be working with in this curriculum who may have personal experience with intimate partner violence, substance use, coercion, and supporting them if these conversations are challenging, difficult to be part of the curriculum itself?
Yes, thank you so much for that question. So, something that we made sure to do from the very beginning was include a lived experience faculty member and project team member from the very beginning. Far too often, people with lived and living expertise get included as an afterthought after things are well underway, and then get told that it's too late to change something or it's too late to take their feedback on something. And so we started from the very moment that we started pulling together our project team, we also made a point to recruit a living or lived experience faculty member and project team member. We also made sure that that person was paid and that they were paid equal or more than the other people in the room. Understanding that many of us in the room had institutional support that was really covering our time as people who were, at different organizations, as people who were salaried at different organizations. We made sure that what we were compensating the person was matching or more than what we were being paid, and that they were being paid in a way that was routine, that was predictable, that was according to an established set of kind of outlines. And so it wasn't just sporadic or random or unpredictable. That was something that was really important. And then we also spoke with the person around, and they also voiced to us what some of their support needs were and how they were experiencing the project. And so we also both made space for that, but also really listened to her and really made space for her to share with us and took in from her experience and her expertise. We had a lot of people with lived experience on our project team, including myself. But something that's really important is to not just have that as kind of ticking a box of lived experience or lived expertise. Because when I'm a member of the project team and I'm wearing an institutional hat, that's very different than somebody who is wearing the hat of the lived or living experience expert on the faculty and on the project team. Whereas I certainly use my personal lived experience to inform my work, it is very necessary and important to have people who are also only coming from the lens of living or lived expertise and the ways that they can use their lived or living expertise to challenge some of the norms within our institutions. And if we're also wearing an institutional hat, that becomes really messy. And it's really not realistic to be both part of an institution while challenging the institution. And so we really need people who are only wearing the living or lived experience hat to be able to give full voice to what doesn't work and what needs to change in order to create access, safety, and effectiveness to healing and well-being and safety for survivors. So that was really critical. We also, with the lived or living experience experts, I would say, with consensus from them, we also made sure that when we got to the faculty feedback part of our echo, we always started with their voice, right? So it was always their voice front and center through that interaction. And then other folks on the faculty panel would then add to. And then if you go ahead and look at the full 12 session, you will see that 4 of those 12 sessions also had guest faculty members. And amongst those guest faculty members, it was really important for us to recruit people who had lived experience and expertise in the area of specialty knowledge that they were speaking to. And so really continuing to find additional ways to always be including the voices of people with living and lived expertise.
Yeah, and I'm listening to all that. I think that it creates an environment that is trauma informed, survivor defined, and very caring. Because we also need to remember that people getting trained also bring a whole constellation of forms of lived and living experience.
Thank you. I think I'd like to end on that discussion on lived and living experience because I know as Immerse as an organization really values the expertise of those with lived and living experience. And I think it really grounds our really excellent conversation. So I just appreciate you both so much and your organizations for all of the work that you all have done. Thank you for this incredible conversation. I'm Gabriella and Heather. Before we wrap, I just like to put a few key takeaways for folks who are listening that substance use coercion is common and it's under-recognized form of abuse that directly impacts folks' recovery and their safety. That cross-sector collaboration, working between our various different silos between domestic violence and substance use disorder treatment programs is essential. It's the work that we need to do, and it's our job to be part of that breaking down of silos. Substance use coercion Echo Toolkit provides free evidence supported tools to build clinician and staff confidence and strengthen systems of care. For folks who want to expand on that toolkit, there's the workshop that Gabriella mentioned and the more abbreviated toolkit that will be made available. So look for those dates coming up. And to our listeners, thank you for being part of this important conversation. We encourage you to download the toolkit, share this episode with a colleague, and take one concrete step towards concrete cross sector collaboration this month.
That was Gabriela Zapata Alma and Heather Phillips in conversation with Dr. Jimena Levander on substance use across the lifespan, supporting every stage. Thank you to Dr. Levander, Gabriela, and Heather for sharing your insight and expertise. And thank you for listening. We invite you to continue your learning with this episode's companion toolkit and live workshop. You can download the toolkit by completing the episode's evaluation survey and then join us for the workshop, where we'll take a deeper dive into practical strategies for implementation and cross-sector collaboration. You'll find both the survey and workshop registration links in the show notes and at immersa.org. We hope you'll tune in next month for the next episode of Substance Use Across the Lifespan, when we welcome Mel Ramage, Dr. Andre Jones, and Dr. John Larrabee to explore the gap between evidence-based perinatal substance use disorder care and everyday clinical practice and practical strategies to build that bridge. In the meantime, join us in 2 weeks for the next installment of Immersa's other podcast series, Frontiers in Substance Use Care, Emerging Topics and Evidence, where we explore the evolving landscape of substance use and addiction care. This Immersa podcast series is created in partnership with the Opioid Response Network. To learn more about Opioid Response Network and Immersa, please visit opioidresponsenetwork.org and immersa.org. Technical production is provided by Podpaste. Funding for this initiative was made possible, in part, by grant number 1H79TI088037 from SAMHSA. The views expressed in this podcast do not necessarily reflect the official policies of the Department of Health and Human Services, nor does mention of trade names or organizations imply endorsement by the U.S. government. Disclaimer: the information, opinions, and recommendations presented in this podcast are for general informational purposes only and should not be considered medical advice. This podcast is not intended to replace professional medical consultation, diagnosis, or treatment. Any reliance on the information provided in this podcast is at your own discretion. While every effort is made to present accurate and up-to-date information, EMRSA makes no warranty, guarantee, or representation regarding the accuracy or sufficiency of the content featured. The views expressed by guests are their own and do not necessarily reflect the views of EMRSA. Their appearance on this podcast does not imply an endorsement by EMRSA of them, their viewpoints, or any entity they represent. Unless explicitly stated otherwise, EMRSA does not endorse, approve, recommend, or certify any information,